Folks, you're very welcome and apologies. As we're just saying ourselves, technology is very good when it works, but when it doesn't, that's what we experienced. So we did. So we apologize. But we're up and running now, which is the most important thing. And we're all here, and it's lovely to see you all. So first of all, thank you each of one of you for joining for today. We are running this event for our menopause events that we're running for October, and Menopause Day is on the 18th of October, which I'm sure you're all aware of. And it is lovely to see so many people have joined in today for the event as well. We have a fantastic panel lined up for you. We have Dr. Lisa Nelligan, we have Dr. Frances Stewart, and we have consultant dietitian Gillian Kellner. Now, I'm not going to go into the detail of what each of them are, their backgrounds, because we'd already said that to you when we sent out the promo for today. But I'm sure each of them will explain themselves when they start doing each of their talks. So I hope you find it very informative, the session, and we will have an opportunity for you to ask Q&As as well. And Una's going to just explain how we're going to do that. But what I would say to you is be open and honest with questions. This is a session for yourselves. And the last time we had a session like this for the fire service, everybody was very open and honest, and it actually ended up being very informative, and we got such great feedback. So don't feel there's a silly question or there's a question that shouldn't be asked. You ask because this is your session for you. So enjoy, folks, and I'm going to hand over to Una just to give you the format of how we're going to work.
Good afternoon, everyone. Thank you so much for bearing with us. It's been a bit of a disaster, but look, we're up and running, and rather than waste a lot more time talking about it, I just obviously want to get everybody going. Unfortunately, working in a hospital, things do happen. Frances and Lisa will have to do their bit and go. So but then Gillian will be able to come on at the end. So the way we're going to do it is we're going to have Frances go first. She's going to talk you through her bit, and then we'll have some Q&A for Frances. Then we'll have then we'll have Lisa. Lisa will do her bit, Q&A for Lisa, and then we'll do Gillian.
Okay, everyone. Well, thanks again. I'll repeat the thanks to everyone for your patience and everything for us to talk through this really important subject. And as the speakers said, I'm Dr. Frances Stewart. I'm a consultant in gynecology, and I am specially trained with regards to the management of the menopause, which I know is our theme today. Affects all of us. I absolutely guarantee, and affects those around us very much. And I spend a lot of my time seeing women trying to navigate through both the perimenopause and the menopause. And I think it's important for us to kind of talk about that, because sometimes people are in the middle of this and they don't actually recognize that that's what's happening to them. So the first thing I want to say is the menopause. So what is it? So the meno stands for your menstrual cycle. And therefore, it's literally describing a pause in your menstrual cycle, as in your menstrual cycle stopping. You're actually said to be fully within the menopause itself when you've had no periods for a full year. And this means that your ovaries have ceased from working, they've ceased from secreting those cyclical hormones, or your glands in your brain telling the ovaries to do that. So that has disconnected, and you get a significant fall in particularly three major hormones, including your estrogen, your progesterone, and your testosterone. So all of us produce these three hormones, and then once we hit the menopause, they do decline gradually. I'll come on to the perimenopause. They do decline gradually, but then once you're in the full menopause, then those hormones go completely down. I'm just admitting something else. So the average age for your periods to fully stop is around 51. and the average age for the perimenopause is 45. And when I talked to that in a bit more detail, but the perimenopause is something that's very difficult to define because it's the start and the end of it and the longevity of it, and it's very individual. Early menopause is defined as that occurring before the age of 45, so that's all periods stopping before the age of 45. And premature ovarian failure is another condition where your ovaries actually stop themselves, more probably we think because of an autoimmune response, and that would be before the age of 40. So, and first of all, why is the menopause such an experience for women? And it's because one of the main hormones that falls significantly, i.e. your estrogen, which I'm sure we've all heard of, affects so many organs in the body. And one of the big things that women will come to see me, particularly people like yourselves, they're working full time, they're managing a family, you know, the youngest is 14 and suddenly, you know, they're a nightmare to live with, they're in the room all the time with their hormones, etc., etc. So you're at that edge of your hormones and they're at the other edge of their hormones. And patients will come and they'll say, I just have brain fog, I don't know where I am, I can't remember my own name or my PIN numbers or things like that. And they get a real significant loss in their confidence. They're in a meeting in work and they kind of go, oh God, I've worked with her for 2 years and I can't even remember her name. It can be really disconcerting, and that chips away at a woman's confidence, that chips away at her ability to kind of be present, to be relevant, to be in the room and say, actually, I've got a lot of experience and I am very relevant in my workplace. So that's something that really nags at women and can be very, very difficult for women to deal with. The other thing, skin. Women can say, I'm going for the kind of more, you know, common symptoms, but symptoms that sometimes aren't. Actually, that's the menopause that's doing that to me. So patients will come to me, and I'm sure Lisa would find this itchy skin, dry skin, skin changes, coming much more sensitive to the moisturizer that they've been using for 25 years, finding that their skin is just not what it used to be. And again, that's very much estrogen driven. Bones. So your bones, the density of your bones is extremely important. So the mortality, i.e. death, the death rate of a fractured hip above the age of 60 is 50%. Now, by that I mean is that, you know, obviously that's incorporating your 99-year-old woman who has a fall. But what we've got to be very important. So if you fall because you've been silly in Tesco's or something, or you've fallen over something, you've fallen over the new puppy, and you have a stumble, you're embarrassed, and you get up and you get on with the rest of your life when you're 65, that's absolutely fine. It does not impact you, and it does not impact your long-term health or age. You're just a bit bruised and a bit embarrassed. If you fall and your bones are thin enough to actually fracture a bone, i.e. fracture a hip, about when you're 65, 67, the surgery is required, the recovery that's required, the impact on your mobility, your weight gain, and all the other things that you may or may not be dealing with in your life is huge. And it really ages women. So it's so important that our bones are strong, that we're feeding our bones both with vitamin D and hormone if that's required. And it's very important that bone density is something that women look at and are aware of and get the correct advice as to ensure that you don't tend to be able to reverse your bone density, but you can certainly halt it. There's very good evidence for that. And so that's something that, again, is imperative that we protect, because it affects our quality of our life, our aches, our pains, but it very importantly, it's knock-on effect of an injury if our bones are that thin that anything can make them break. Heart, there's very good evidence with regards to estrogen's protective factor with regards to the heart and about your cardiac health. So when a woman's estrogen is very low, it is said to have a very negative impact on your cardiac health. So that is something that's in your family history, for example, or something that's even in your own medical history. That's something that then that should be taken into account when you're deciding whether or not hormone replacement, for example, is the right thing for you or not. So urinary function is again something I will see loads about. So patients who start to notice a certain level of leaking, incontinence, feeling very sore down below, feeling that, you know, as soon as they get into Spraysfield, the first thing they're looking for is the toilet. That kind of feeling that, you know, my bladder is the size of a pea. All of those things are frequency, feeling, oh, I've only just been, I have to go again, and all the rest of it. That obviously can be multifactorial. But again, what estrogen does, it keeps the skin and the bladder nice and soft and supple. It allows the bladder to be distended up and hold a decent amount and then close properly. It helps the bladder surrounded by a very fine muscle, which allows it to contract. And it helps that contractility of that muscle. So estrogen is very important with regards to your bladder function. Another big thing that I would say, and this is something that's kind of be difficult for people to talk about, and that's something about that's around the kind of integrity of the genital skin. How sore and how thin the skin can get down below. And that can have a huge factor on a woman's, first of all, her comfort. She can be very uncomfortable in work. She can find she's having to adjust what she can wear, where she can sit, how long she can sit for, et cetera, et cetera. So it can be really itchy and burny and sore. And one of the other big things that I will see is women will admit to, you know, intercourse is not possible for me. You know, for example, I'm only 52 and I can't tolerate penetration. And that is because, again, the skin loses its elasticity. So every time you try to have intercourse, in actual fact, you're splitting the skin. So again, topical estrogen can be really good for this. Sometimes it requires a small procedure. It just very much depends on the patient. But intercourse should be a choice. I'm not saying you know, you get a certain stage in life and you're not, you know, I don't want to do it all the time, but I want to have the choice to be able to do it and feel that it's comfortable for us as a couple. So that level of intimacy is something that's very important. It shouldn't be ignored. So as I say, low estrogen levels can affect all of these areas of the body. So then talking about the perimenopause. Now, and it's well documented now, but in my experience, the perimenopause is actually worse than the menopause itself clinically. Patients, I would describe it, are in a storm. Okay, so 1 minute the hormones are up here, the next minute they're crashing down. They're all over the place. You dip in and dip out, you dip in and dip out. So the perimenopause is that time whereby a woman's estrogen or her woman's ovaries are not working as efficiently as they were when she was 25. But she's 45, she's got a young family, she's got school runs, she's got football practice, hockey, or whatever it is. She's got a lot of pressure. She's also dealing with somebody in work who's horrible. She's also dealing with money issues. She's also dealing with this, that, elderly parents, caring, all these facets to your life. And your hormones are in a storm in the middle of that. So women would say, oh, I've noticed a big difference in myself, but then I was okay for a couple of months and then it settled down again. I thought, oh, but those around you will see the difference in you. They'll see you're on your last nerve. You'll come into the kitchen, spotlessly clean, but there's a cup on the side and you're like, why can they not fill the dishwasher? Everything about life just gets on you. You're on your last nerve. You want to be on your own. A lot of these women will describe that they would just love to come in, go to the room, just be on their own all evening. And I mean, we all can be like that at times. I'm not done doing menopause, that's just life. But my point is that those women are starting to feel a real change in themselves, their friends, their sisters, their mom, their husbands, their daughters. People around them start to really notice that difference in them, and they feel they're turning into somebody that they don't particularly want to be. And secondly, the other big thing that I see is women would say to me, I know what my mom went through, because they watched their mother go through this and they kind of go, I get it now. My mom changed. My mom turned into this person, and they just don't want that for themselves. So as I say, it's a time before your periods actually fully stop. So those women can even go from like a monthly bleed to say, look, I'm just missing the odd period. I go 3 months, no period, then bang, it's back. And I find as well, all these women, their periods will have got a bit heavier. Some say it's a bit lighter, but most of their periods get a bit heavier. And sometimes the periods can actually come closer together. So what I'm saying is the pattern of the period becomes a bit more erratic. But as I say, they're still having the periods, but they feel symptomatic. One of, I don't know if Lisa's seen this in her practice, but one of the big symptoms in the perimenopause that I see time and time again is anxiety. Now, I know we live in a fast-paced life. I was anxious about this meeting today because I couldn't get on the IT, etc. We lead active, busy lives. We all do, having phones and scrolling and wasting time and all the rest of it. But that level of anxiety, where, as I described, you're living on your last nerve, they start to get very anxious about everyone around them. They know that their anxiety is more in a kind of a pathological scenario where they have that horrible feeling in the gut of their stomach pretty much all the time, that kind of like hungover feeling. So that feeling of regret, that feeling of dread. And again, I see that very strongly within the perimenopausal years for women. It's very difficult for these women to get help. They can go time and time again to health professions and be told, look, your periods are still coming, you're not menopausal, bye-bye. And that's really frustrating for these women. And that's to do with lack of education. That's to do with not individualizing the care for the patient. And yeah, it can be extremely frustrating, and that adds to the pathology of this all. You know, I am going mad, nobody's listening to me. A lot of these women will get offered an SSRI antidepressant prior to them ever being considered for hormone replacement. And again, we're doing these women a disservice. These women are not depressed. Depression is a very clear diagnosis, and it's very different from a perimenopausal woman. So in my experience, a lot of these women will come and say, look, I've just been offered an antidepressant, but I'm not depressed. I don't feel depressed. I just feel all over the place and unable to manage. So the perimenopause can last a short time, as in your periods then eventually stop. So you start to notice a difference when you're 45 and a half, and by the time you're 46, your periods have stopped completely, and then 6 months later you're defined as menopausal. So that's okay. So the other thing is that then it can last for many years. It can last for a significant amount of time. These women, as I say, can dip in and dip out of the menopause. You could start this process, you know, in your early 40s, and you're still dragging through it and having intermittent periods by the time you're 48, 49. And as I say, it's that roller coaster of the hormonal changes that make it very difficult for women to cope with this time. And I find it, you know, really difficult for women. So why is it important? So the menopause is important because I don't think it's as high as this, but I'm sorry, I think it's higher than this, but at least 50% of women will will describe a very negative impact on their ability to work, to interact. And a lot of us, our work is part of our social life, is part of our friends, etc. So they notice a significant negative detriment to their ability to do that. They start to, so I've heard every story. 32% of women feel that they are no longer good company. 38% of partners say that they feel helpless, and that's very true. And I'll get that, like my husband is so good, but I haven't been able to have sex for 2.5 years. But he's so good, he's so understanding. And I know that there's more to relationships than sex, of course there is. And but the menopause can be a time where a lot of things are best left unsaid and they just slide. And again, I don't think that's good enough for women or men. 23% of women say they feel isolated. It's way more higher than that. And this is just going by the data that's out there. And 51% say it affects their relationships. I'd say that's 100% for women who have significant symptoms. Menopause is not horrible for every woman. Some of them, I sailed through it. But I've never met anybody who hasn't had something, but it's all about perceptions. So physical symptoms. So these are the things that you read about: the hot flushes, the night sweats, the insomnia. So patients might get over to sleep and then the next thing they're waking up, the duvet's off, the duvet's on. They're roasting 1 minute, they're freezing the next. They can't live, work and sleep in anything apart from the lightest of nighties. Another thing that women will describe is they get up in the mornings and they feel all in one piece. They feel achy. They feel as if, oh, once I get going, then I'm starting my day, but they just feel like 105 when they get up in the morning. Headaches, again, is the headaches through the stress of just going through all of these changes, or are headaches really a problem? It's hard to say. And again, as I say, skin problems is something I'll see quite regularly. And it's when you directly ask the woman, have you noticed this change? Oh yeah, I do, but I didn't know that was connected to this. So 85% of women get the hot flush. And why do you get the hot flushes? Well, estrogen is really good as being your temperature thermostat in your body. So because that thermostat is faulty, then your thermostat overshoots and undershoots. So 1 minute you could be freezing, the next minute you can be hot. You know, I have literally in our gynae office, there's about 6 women share the gynae office, and I've literally been in the middle of that with them all shouting and going to kill each other because somebody wants the window open, somebody wants the window closed, and fans are involved, the whole 9 yards. So we all have been there. So 20% of women say they're really severe, they disturb their sleep, and they feel very embarrassed by them because there's no control over them. And when you have a hot flush, a woman will describe it, I feel as if it's roasting, but you looking at her mightn't see any difference. But some women, you can see them, their skin start to get quite red. So as I said, it's about that temperature control what's in the brain. And again, it's this inability for the estrogen to be as efficient at controlling that in the regulator. So the body thinks it's overheating, so it vasodilates all the vessels and you get this hot flush. So these are the things that people come to get help about. People know what hot flushes are. I'm, 52 and I'm having hot flushes, it's my menopause. But what women really complain about is the impact on their mood swings. This kind of extreme pendulum going from one side to the other next minute. And I've had women diagnosed with all sorts of, mental health disorders, bipolar, all of these different conditions, personality disorders, all of those things. And in actual fact, they just need their menopause managed. But I'm not saying that everything is because of the menopause, and that's really important. I'm not saying that everyone's answer is, oh, just put you in HRT. This should be personal. This should be specific to you or what you need. Irritability. I don't know about you, but we're all a bit irritable at times. I know I am, but irritability to the point whereby breathing is enough to set you over the edge. The way someone's eating and from anything at all, that kind of level. And it's, to me, it's a bit like PMT on speed, where you kind of like, this is what I'm like years ago when I PMT. No, this is like literally anything just gets on your goat. Anxiety, as I say, is a huge thing that I see, and difficulty concentrating. I had a lady one time came to see me. She's about 54, really experienced in her job. She was like CEO of some big place, very big organization. And she said that for the last 12 months, she just is quietly quitting. She just sits in meetings and she just is quietly quitting. And I think that it really struck me. I was like, are you telling me somebody with your level of experience as well? I just listen to these other ones coming in and I'm just letting them chat because I'm just quietly quitting. And I think that women in the menopause can do that. They can quietly quit at their career. They can quietly quit at their relationships, at their friendships. And that's not what we want for women. You're better than that. Difficulty coping, forgetfulness is another thing. They all come in, women come in, I'm sure Lisa's the same, they all come in, Gillian's the same, they all come in with their books and their lists and their writing down and everything else. And I mean, that gives us control, and that's all that that's about. And we all can get a little bit forgetful, but it can be to the level where women are really starting to worry about their cognitive function. And all of these things could be related to your hormones. And I'm a great believer in trial of therapy. So often I'll treat patients and see them back because I want to know, does this make any difference whatsoever? And if it doesn't, why not? So again, we talked there about sexual symptoms. So vaginal dryness is something that we can treat with topicals. We can treat locally, we can treat in a more sustained way, depending on why the skin is dry. Losses of libido is something that I see very significantly among women. Again, this can be women who are already on HRT, and then they come to this and they say, listen, honestly, if I never had intercourse again, it would be too soon. You know, they pretend to be asleep when their partner comes to bed. They just do not want any physical contact. And that really is something that should be addressed. And again, it can be a trial of treatment. Now, the thing about libido, as in your sex drive, it's so multifactorial. You know, if you're married to an asshole, nobody's going to want to have sex with him, just to be frank. If you are very sore down below, you're not going to want to do something that makes you really sore. If you don't enjoy intercourse for whatever reason, why would you have the libido to do that? So it's about picking all those things apart and ensuring that we're trying to target it. But often, and then not, it can be because your testosterone is very low. And there's no doubt, for me, women on testosterone therapy will notice a bit of an improvement in their libido, but it tends to, you know, it's not that they're like, you know, jumping off the wardrobe every night. They tend to have an improvement in it, and that they go, yeah, I can take it or leave it now. I quite like it. It's fine. We're back to our baseline. But for me, the testosterone is very good at giving women that get up and go again, giving that women that drive, giving the women their energy levels back. And that actually is where I see it when it's appropriate. It's not needed for everybody again, but in a woman who I have on HRT, and I've checked her levels and I'm happy with her absorption rates and I'm happy with where we're at. And she said to me, look, I've went from 3 out of 10 till about 7 out of 10. And then we pick down of what the things are. Often it'll be energy. Often it'll be, I still feel knackered, I still feel this, I still feel that. And sometimes we'll top that woman up with a short term course of testosterone, and again review her and then see, look, is this what the missing part of the jigsaw was? It's not required for everybody, but now I must say we are seeing very positive effects with it. So as I said, so you improves your feeling of well-being and your feeling of you get up and go. So like everything, there's pros and cons. So the benefits are your symptoms are going to improve, you're going to make your bones stronger, you're going to reduce your cardiac risk, and you actually decrease your risk of bowel cancer, osteoarthritis, and type 2 diabetes and depression. So those are all clinically significant, statistically significant benefits of being on your HRT. The biggest factor that women come to me, they don't come to me and say, oh, I want to, well, few do, but some come to me, they don't come to me and say, look, I want to make my bones strong. They come to me with symptoms. The risks for most women definitely outweigh the benefits. The increased risk of breast cancer is very small. Breast cancer is extremely common. It's affecting 1 in 8 women in Northern Ireland, perhaps 1 in 7. It is an extremely common disease. End of. We can't get the 2 biggest risk factors for breast cancer is being a woman and getting older. There are other things that are reversible that have a far bigger impact on your breast cancer risk. So if your BMI is over 30, you double your breast cancer risk. If you drink more than 14 units of alcohol a week, you bring up your breast cancer risk by about 40%. If you use transdermal estrogen, right, so estrogen actually through the skin, when you're not having to take any other hormone with that because you say your womb is out, there's actually good evidence that that actually reduces your breast cancer risk. Having said that, it should be used prudently, it should be used correctly. You don't put people on mega doses. And I mean, I appreciate there's been a bit of publicity around HRT and things like that. But I think what's really important is that you're seen by somebody who knows what they're doing, somebody like, you know, a GP at the level of Lisa or somebody like myself, someone who is going to tailor your treatment to you. I have women who have a diagnosis of breast cancer themselves, have been treated successfully, and they've come out the other end, but they are going to jump off a bridge if they do not get their menopause sorted. And through significant discussions and not testing, but discussions and counseling, things like that, I am here, I'm talking to their GPs, etc. We are here to accommodate the woman. That's like me saying to you, look, I don't, you know, I'm not prepared to take that risk. There's some women who will take risks because of the outcomes for them, and there are other women who won't take even the minuscule risk, and that's fine. This is all about choice. None of this is compulsory, and none of this is, you know, taboo either. I don't strongly encourage anybody with a history of breast cancer to use HRT. There's good evidence about recurrence of disease and things like that. So it's not something that I would obviously do routinely, and certainly I would be looking at lots of other ways that we could manage the particular symptoms depending on what they are. Blood clots or migraine, again, we now use what we call body identical HRT that mimics the actual endogenous hormones that we already produce. And because we give it through the skin, we do not actually increase blood clotting risk or things like that. So the key points are that there are more benefits to HRT than there are detriment. The menopause means you're living in a world of hormone deficiency. There's no maximum time to stay on HRT, and there's no minimum. This is all individual. This morning, she's 82 years of age. She comes to see me every so often so that everybody in the room is happy for her to continue her very small dose of HRT. This woman came in today, she's 82, she looks 62. She had a fabulous wee outfit on her. She drives her own car. She's away out to meet her girlfriends for lunch. She's living her life at 82, and that's what she wants. She wants to live her life at 82. And if having 25 mics of transdermal estrogen is what makes her do that, well, that's fine. Because that's a very, very small dose, and what she's tried time and time again to come off it, and she just goes really downhill with that. So there's no maximum time to be staying on it. The other thing the patients sometimes would ask me, well, is there any point in me taking this? Because I'm going to have to go through this eventually. Am I going to just kick the can down the road? Am I going to start treatment now at 50? And then when I come off it at 55, I'm going to then have my menopausal symptoms. If you come off HRT after being on it for 4 or 5 years, and you start to get symptoms again, you were always going to have those symptoms at 55. You don't adjust the timing. There's some women, their menopausal symptoms go on for 10 years. It's just very dependent on the patient. What you've done is you've treated her for 5 years. Your menopausal symptoms were going to last longer. And in actual fact, you just come on at that a little bit too soon. So I put those patients back on the treatment, obviously. Obviously in the absence of any other contraindication. So again, and it's absolutely the balance app that's out there, various commodities that are out there for us to be able to kind of calculate exactly what's right for us, but it is a balancing act. And I, in all the years, will not share how many years, but in all the years that I've been seeing women, I have never met two women the same. Everyone has a slight difference in their story. Yes, their treatments might be similar or their stories might be similar, but there will always be something specific about that particular woman and her case that make it that it should be about her. So it is a balancing act between what's right for her and what's wrong for her at this particular time in her life. You know, I see women where I'm saying, look, you've got X, Y, and Z going on at the minute. This is what we're going to do. So as I say, it is very much a balancing act. So again, back when the Million Women study came out, there was a huge amount of poor publicity around hormone replacement. And it really did inform women in the wrong way. And it was all about the interpretation of the data. This was a big study done on women who were much older than the normal cohort. They were way above their 60s. And it was done with oral HRT, and that's not something that we use. So, you know, essentially a generation of women missed out on this treatment. And as I say, I don't want to come across as if I'm like pro HRT all the way. I'm very supportive of HRT, provided it's given to the right woman in the right way, at the right dose, with the right follow-up, for the right time, for the right reasons. So it's much more complicated than just take a pill and go away. So as I say, we just touched on breast cancer, because that's the one thing the patients, like I had a woman earlier today who said like her aunt had breast cancer, so she decided to never take it. She's now got really bad osteoporosis. She's in her 70s. She's got a terrible prolapse, and she never had a contraindication to breast cancer or to HRT. But however, you know, women will avoid that, but they'll continue to be overweight and smoke 40 a day. So it's all about, again, the education of the quantity of risk, okay, and what you're doing and what the impact is. So these are the other things that we need to be wary about. BMI is a big one. So BMI below 30 all the way, that is where we should be. That is hugely important for your quality of life. It's hugely important for your short-term and long-term health in every possible way. Having a BMI over 30 increases your risks of everything, from cancer to heart disease to everything. So again, that's just about the breast cancer risk. You can see this here where I'm talking about women are overweight. So the dark purple is the additional women if you're overweight. Okay, and then if you take a combined breast cancer, you can or HRT, you can see that it's only 4 women. So I know that's a bit. This is more kind of to give you a graphic of the impact of weight versus the impact of other things. Okay, so it's really important to take that in mind. So the types of HRT you can get are estrogen. You can have estrogen, progesterone. If you've got a womb, you'll need that. You can have the ones that make you bleed. You can have ones that make you don't bleed. You can patches, gels, testosterone. And we used to have implants, which were great as well. And I think we should be moving forward. The market is a bit confined at the moment as to what we can offer women. So I'm hoping that the next 5 years is going to continue to show an improvement in what we're able to offer women. As I say, in my practice, I only utilize body identical hormones, and the safest, they're the most regulated. I don't go down anything other than that. There's other things that can be offered, but I don't go down that road. Estrogen, I tend to always give through the skin unless there's a reason for that. You will have some women who are really bad at absorbing estrogen through the skin, and I'll go down the oral route with them. I use progesterone that has a minimum side effect profile, and I often use Marinas. I like them. I don't think they're for everybody, but this is a wee coil that sits inside the womb and reduces the blood loss. It's very good for women who also need contraception. So anybody below the age of 50, I would suggest they need contraception. And it's very good for that woman who comes to see me. Yes, I'm menopausal, but my periods are horrendous. They're really heavy. So this will treat everything for us. It's just what everything contains. So as I said, the gels. So where do you put the gel? So you tend to put the gel on your upper thigh. So a little tip, if you're on a gel, so the gel this isn't a gel, but it'll often come in a thing like this, is the estrogel comes in this. You take off the top, and on your leg, I can't show you my leg, I'm not that agile. So you would put on, this is just a cream, but you would put that on to your skin. So just on 1 or 2 pumps, and then put the top back on the gel, and then use the top of the bottle just to rub it into your skin, and there it's away. Okay, and you can just let that dry off. Just let it dry off. And what that is avoiding is you rubbing in your estrogen, right? And then going and washing half of it off the top of your hands. And as well, this part of your skin isn't very good at absorbing the palms of your hands. It's really waterproof. So putting it onto your upper thigh usually, and as I say, put the top back on, and then rub it. So, and that means you're getting the maximum dosage in, you're getting the max. So if you're on 1 pump, 2 pump, you're getting the whole of it usually. And it's over time that this dosage builds up. It's the same with testosterone. If you're putting on testosterone, you put on usually 1 pump every other day. And again, you put the top back on and you put it on the opposite side and you just rub it in. And usually you put them on your upper thigh or your lower abdomen. It doesn't matter. We tend to tell you to avoid arms, although there is no evidence behind that. But there's someone just said, oh, it's a bit closer to your breast, don't put it on there. But there's absolutely no evidence to support that. And in actual fact, the manufacturers give you a video showing you people putting it on their arm. But if you can put it on your leg, put it on your leg. It doesn't matter if it's your inner thigh or outer thigh. I don't know where this inner thigh thing came from. Maybe it's because they feel it'll rub less off on your clothes. I don't know, but it doesn't matter if it's your inner thigh or anything like that. And it's best to rub it in and then let it dry, and it tends to be absorbed very, very quickly. So I would say to women, if they're doing it at night, put the pump on, rub it in with the top of it, brush your teeth, and by the time you're done, you should be finished for your day, for your treatment. Sprays, yes, I quite like sprays. Again, sprays are good, so you just pump the spray on your inner arm. The problem with sprays, again, is I don't think you get the same drug absorption. So I'm not sure that I see much of an advantage of them. Sometimes when you're trying to get women on an optimum dose and you're using a gel, you can end up having to use more gel, and then it becomes a bit of a mess. So, you know, and that's why sometimes patches in those circumstances can be good. But patches can be difficult sometimes to stick. A good tip is to hold the patch, don't put it on over moisturizer, is to hold it until the patch is heated. Sometimes putting the hairdryer on the patch allows the gluey stuff just to stick properly. And the patches can be very convenient because you're only changing them twice a week. And they usually stay on with showering or swimming or things like that. But, you know, for example, I had a woman who swims most days, you know, patches are not going to be appropriate for her. So the progesterone element of your HRT, that is because you're taking estrogen, and the lining of your womb loves estrogen, and it makes the lining of your womb grow. But we don't really want that, because you can then develop abnormal cells. So a very safe way to protect that is very easy. You just give the woman progesterone. Some women are just starting their progesterone, starting their HRT, and they still have a period as such, or it's been less than a year from the period. We give them 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off. So we kind of mimic their cycle. Then we have another element of women who are a bit further down the road from that. And they're women who, in actual fact, have had no bleeding for more than a year, and then we just give them progesterone every night. We always take the progesterone at night because it can make you a little bit sleepy. And then the other way that we can control things, as I said earlier on, is to use a device, the recoil device called the Mirena. Yeah, some women can be quite intolerant to progesterone. So someone will say, look, Frances, I'm great when I'm off the tablet, but I'm horrible when I'm on it. And it almost mimics this kind of PMT scenario. And I would see a lot of women who've got really quite severe PMT. And in those women, we can change things around. Sometimes I find the Mirena is better because it's a lower dose and they're not taking it through their gut, they're not taking it like a tablet. The other thing is you can use these tablets vaginally, and so you just put them into the vagina every night if that's what you're needing. And they're not licensed that way, and the GPs get a little bit uppity about it, but in actual fact, it's very effective and it's very, very safe. So there are ways around that if the pills are making you feel not great for you. So testosterone. So again, this is something that patients ask about a lot. And I know I've spoken about it a bit, but again, the testosterone is given in a gel format. It's given every other day. You rub it into your thigh the way that I told you. You can change the site, usually alternate sites. And women say to me, oh God, I don't know if I'm going to be able to remember that. I would say to them, right, pick the even numbers in the month. So if you're starting your testosterone on the 2nd of the month, you can get to the 20th of the month and you go on an even number and even testosterone. So that's quite an easy way to remember if you're on a testosterone day or not. The big thing, as I say, is the improvement, is the energy levels and brain fog and the libido. Those are the things, that feeling of well-being. Is it because you've got more energy and more feeling of well-being that your libido goes up and you've got more time and energy and all the rest of it to invest in your relationship? Perhaps so. It's hard to know. Vitamin D is something that every woman over the age of 45 should be on as a regular. So I have one in the front of my car, otherwise it would never happen with me. So it's just comes in a little spray bottle, and I just spray it under my tongue every day that I'm in the car. And I usually give myself 1,000 units per day. Vitamin D is a hugely important element. It's important for bone absorption of calcium, and it's again, I see it very good for like the general aches and pains in women, and they really improve with that. So again, it's cheap, it's risk-free, and there's lots of very good things. So every woman I see, I would encourage her to be getting onto the vitamin D. The other things go without saying. Don't smoke, exercise every day, and don't drink too much alcohol. You know, be Mrs. Perfect. Now, life isn't always that way, but we're talking on the law of averages. Everyone has a good week and a bad week, but your core should be, so smoking is never a good idea. Smoking will catch up on you. There is no doubt about that. I know everybody's got a 92-year-old granny who smoked 40 a day and never had anything wrong with her. We get all that, but smoking is a mug's game, so smoking is a definite no-no, and there is no point in investing all of this in your life and saying, you know what, I am going to turn things around, I'm going to start looking after me, I'm going to put myself first, and continue to smoke. It's just, you know, it's a no, and it is really bad for the menopause. Exercise is excellent in so many levels, and I say to women, even if it's going out for 50, I'm not talking about, oh, well, I'm going to get a PT and I'm going to join the gym and all those things and put money into stuff that I'm never going to use. Go out for 15 minutes. That's it. Go out for 15 minutes, put your AirPods in, listen to someone like Mel Robbins or these really good podcasts that are out there. She's brilliant. She's a bit annoying with her American accent, but she's really good at what she talks about. And somebody like that, go out 15 minutes, just on your own. And, you know, oh, I'll come with you. No, you're fine. This is me. I'm just going out 15 minutes on my own. And you will get into the habit, in actual fact, rain, hail, or snow, I'm going out for 15 minutes on my own. Now, inevitably, it'll be a bit more than that. But something like that not only is good for your physical health, it's fantastic for you and your head. Excessive alcohol will always increase any of the symptoms of the menopause, even that like horrible hangover feeling. And as I say, it's associated with an increased risk of breast cancer. But it would go against my religion to say that you cannot drink. Of course you can drink, but it's about keeping your units down to 14. So a couple of glasses of wine or a couple of gin and tonics with your friends, of course, it's absolutely fine. You should never feel guilty about that. And in actual fact, if that's your thing, you should be doing it. If that's what makes you feel happy, if that's what lightens your mood, you should do it. Diet, incredibly important. BMI is hugely important. So the big thing is getting BMI down. And work, yeah. Stress, massive factor. But if you can imagine when you're dealing with all this kind of cauldron of symptoms, stress gets into the middle of that. There'll always be a narcissist in work. There'll always be a man who is horrible to you. There'll always be a girl who's funny. There'll always be an awkward sister. There'll always be a child who's playing up. Those problems will always come. And stress is about how we deal with those. Stress, our body should be stressed, but it's all about giving us rational, reasonable thought. That is impossible when you're suffering perimenopausal and significant menopausal symptoms. So don't try and take on that battle. You will not win. So get your menopause sorted, and then you can deal with the stresses of life. Yeah, some women would say, I was brilliant for the first couple of months and now I'm back, I've noticed a dip. And sometimes those women need dose adjusted. There's definitely a placebo effect. Some like, at least I'm doing something now. But it's very important that I know that you're getting enough of this. And so that's where levels can be really, really useful at times. And again, the additional testosterone. what we're talking about today about the workplace, it's really important to recognize that colleague who's struggling, talking about it, things like events like this, all fantastic. Managers supporting people, supporting them. In actual fact, this is a difficult time, a really difficult time. It's not a disease, but it's a difficult time. So, as I say, it's tough. There's no doubt about that. But I think, and I see it, a huge element of empowerment when women are managing their menopause correctly. And that, as I say, it doesn't always mean lotions and potions and pills, but it can be, yeah, this is where I'm at in my life. I'm embracing it. This is what I'm doing about it. And this is what I've chosen. And this is what's right for me. So, yeah. So I'm sorry I fired through that and everything because I'm very aware of the other speakers, but any questions I'll be happy to take.
Okay, so if we want to put questions out to everybody in case anybody didn't hear that, like anybody got questions for Frances that want to come forward?
Can I ask a question, please?
Sure.
Yes.
Yeah.
Is HRT safe to take if you have trouble with your liver? For example, I have a lesion in my liver and I often wonder, you know, would that impact my liver and maybe compromise it in the future?
So it's like a hemangioma or something, is it? Like a cyst or something?
Yes.
Yeah. So I take it your liver function is normal.
Yes.
Yeah. So that's great. So the only way that you will do anything that affects your liver is if you take it orally. Okay. So taking your progestogen orally will not affect your liver. And you're going to have your estrogen through your skin. Okay. So when you take something through your skin, you avoid it being metabolized by the liver. So you're not annoying the liver at all. So that's really advantageous for you. And you can take both these medications through the skin. There's a patch, it's called a continuous patch, and it has both the medications in the skin, in the patch. So therefore you would avoid your liver altogether. So yes, it's very safe and it can just be adjusted for what you require. Now that's if what you tell me is that it's a very straightforward liver cyst or something which we pick up incidentally sometimes on scans.
Yes.
But provided that your liver function is normal, and yes, there's absolutely no contraindication to that. You're not annoying
Okay.
yourself.
Perfect. Thank you. That was a really important question for me. So thank you very much for that.
Good, I'm glad. Thank you.
Thank you.
Anyone else? Feel free, be open, honest.
I know it's a tough old subject to talk about, and you
It is. A lot of
it.
people avoid it, but I would say, Frances, you were so thorough. You've probably answered so many people's questions, so there's probably an element of that as well. Do you want to unmute?
Just the one thing I would say is don't be afraid to ask for help. That's the one thing I get, and I think that women kind of go, oh, the doctors are so busy anyway, and all the rest of it. You deserve help. You deserve it, and you deserve it. It doesn't have to be private. You can go to you're fully entitled to seek this help out through your GP. So, you know, just remember that. Don't be struggling through this. And, you know, sometimes I would have women, and you will know if you start HRT, for example, if that's what's right for you. You would know by 12 weeks if it's making a difference. Usually by about 3 months. And that's when I tend to see my patients back. But yeah, so usually by about 3 months. And as I say, I like women to score themselves and say, right, 2 out of 10, 5 out of 10, whatever. And that gives them like a baseline of where they're at. Like life's not perfect. HRT is not gonna, you know, stop you getting a parking ticket tomorrow. It's not gonna stop crap happening, but it's all about your rationale and you're dealing with things. And I feel age, it's very important to identify that you can be 50 but feel 65, and then you can be 50 but feel 40. And that's where we should be, about your biological age. And that all comes down to your ability to get out there, to move, to be involved socially, to give the commitment and the energy to your friends, to, enjoy your work. We all have to work, turning your work around and saying, this is not something I dread, this is something that's part of my life and I enjoy, and whatever, so it's all about your biological age rather than what your birth certificate says.
So
No,
true.
sorry. Oh, sorry.
No, go ahead, go right ahead.
Can I just ask a wee question? I worry about getting the proper help, and I don't want to say I know the GP
informative. No, honestly, it really, really was. And you've probably answered so many people's questions. It is a topic that, including myself, that, you know, you're going
That's
through.
brilliant.
And
I'm really glad to be able to chat about it. As I say, I know sometimes you get kind of menopause, you're sick listening about it, but it's all right talking. When you're going through it, it is difficult. So, and I think we, as women in a certain stage of our life, everybody else goes first. So, please, if you're struggling or what have you, and while even from Agnes's story already is that I don't, that is classic. I don't feel listened to. That's not on anymore.
no,
So
it's not.
the system is back up and running. It should be helping you. So please reach out. And if you've got that resource to be able to ask Lisa questions, that'd be amazing.
Yeah.
Okay, well, thank you very much, everybody, for having me.
Thank you, Frances.
Lovely
You're a
to see you
star.
All the
Yes.
best. Bye.
Thank you. Can you release Gillian? Right, everybody. We'll I'm going to introduce you now to Gillian. Gillian Kilner. Gillian, are you there? Okay.
I am just switching back on.
Okay.
Hi, everyone.
Yeah, things, because of our tech issues at the beginning, things haven't gone quite according the plan we would have liked, but hey ho, it's the way it goes. So as I say, Lisa will come back. A lot of what Lisa would have said probably would have overlapped with Frances anyway. It's both, they're both one's obviously a GP who specializes in menopause, one's a consultant gynecologist, which is what Frances was. So a lot of what they would have said would have interacted with one another. So the good thing is Lisa's willing to come back after Gillian's session and do a Q&A. And if anybody has to go and leave because work related or whatever, we will give you
Much. Thanks everyone for joining, and I'm delighted to be here just to hopefully give you some critical information, top tips, answer your questions. I haven't got a PowerPoint. I thought from my aspect, a lot of people love to know very specifics, and so you can Google, you can look up so many different areas in and around menopause. And there is no one answer that will suit you. And as Frances was saying, it is very individualized in the hormonal treatment and with symptoms. And actually, quite similarly, it can be the same for nutrition. And that's what I specialize in. And what I did write down is all of the different points that, and there's tons more, but there's 20 points that I thought I would try and kind of cover so that you guys would have a flavor of what kind of areas I think would be useful. So the first one, I think a lot of people are actually, definitely there's mood and sleep and hot sweats and all the things that Frances talked about. And that's driven by a few different factors when we look at nutrition. And many ladies who are now sitting in their 40s, 50s, 60s, when we were all growing up, and I'm in my 50s, I have been in the same place. When we were all growing up, we were told we needed to do low fat, low sugar, low everything, and protein was never addressed. And protein was a very taboo subject till probably in the last 5 to 10 years. And now it's gone the reverse, and protein is in for everything. You need to have a protein shake. You need to have protein before your workout. You have to have protein after your workout. You have to protein and no more carbs. And it becomes extremely confusing and conflicting. And so what I wanted to do was just touch on that so that it gives you an understanding of what aspects you need to consider in and around the perimenopause, menopause, and postmenopause. So when we talk about protein, there are a few different key things you need to be sure of. Protein comes in a variety of forms. We've got protein that is natural. So you've got your meats, your natural fish, eggs, dairy. We've got beans and pulses. We've got nuts and seeds. They tend to be the most familiar ones. We do get some protein in some fruits and vegetables as well. So when we look at a plate of food, we can actually most likely get a reasonable amount of protein onto that plate if you're eating regular meals and you don't have any aversions or illnesses or allergies, or that you're doing something weird and wacky, which actually a lot of my patients come to me and they've done all sorts of crazy things. So that's what I want to make sure we are clear on. So once you are having regular meals and you are someone who eats lots of different choices, then protein can be anywhere from 0.8 grams per kilogram of body weight to up to 2. Now, I don't ever bring anyone up to 2, but I start postmenopausal, perimenopausal women in and around 1.2, 1.5 grams of protein per kilogram of ideal body weight. So if you are carrying some extra pounds, and that is a time of life when we do start to spread, we can gain a couple of pounds, maybe up to 10 pounds in weight, and that's where our muscle mass is dropping, our fluid and fat stores start to increase. And so that side of things can be a bit overwhelming, and so important to keep our protein levels suitable for our actual ideal body weight. So that being said, we're talking anywhere from maybe 60 grams of protein at the lowest, up to 100, maybe 120 grams of protein, depending on how much activity you are, how lean you are, how much exercise you're doing, as I said, and how much muscle you carry. Plus also your age. We actually need a bit more protein as we get older. So that's the whole area. Then we have important aspects in and around omega-3 fatty acids. So if you're a person who doesn't eat a lot of fish or nuts or seeds, or has a balanced diet in that respect, omega-3s are really important for flushing, for hormonal balancing, for inflammation, and that's what often people are experiencing when they don't eat particularly well. Their food choices may not be of the most varied or unprocessed, and that's one big aspect of our very modern day lifestyle, where we grab and go and eat pre-packed foods. They tend to be high in salt, high in saturated fat, high in sugars, and we become very addicted to that, and our gut microbiome tends to like that. And I will touch on gut because it's my specialist area, but we will definitely delve into that a little bit. But what I want to highlight is when we eat a processed diet, we actually don't have a low level of inflammation. We tend to live in an inflamed state, which knocks on the door of putting our hormones out of balance, or making the symptoms more severe. So that whole aspect is really important. Eating more natural foods, keeping your salt intake low, keeping your sugars regular, eating more long-acting carbohydrates, so your higher fiber carbs, your high fiber breads, pastas, whole grain rice, quinoa is really useful as part of a meal. Eating a colourful plate, and then having some protein. And as I've talked about, the protein being a suitable portion, not a tiny portion. So I touched on gut, so let's go there. So gut health, massive aspects of gut health as we go through our whole lives. When we start as a baby, we take our microbiome from our mother if we've had a natural delivery. Otherwise, we get it from the surrounding area and bottle feeding. And through then, as we age, we can pick up a changing gut bacteria for a variety of reasons, and antibiotics will kill off good bacteria as well as bad bacteria. So that all can happen through our age. So then we get to our 40s and 50s, and then we have this shift in estrogen, which then can create actually problems with our hormones and estrobolome, which is a part of our gut bacteria that recycle estrogen. So if we've not got a good gut function and we've got constipation, or we eat poor food choices, we actually can release more estrogen back into the body, and sometimes we can become more estrogen dominant, where we get more symptoms that way, which isn't that pleasant. So again, eating natural, healthy options can assist that further. And for sure, if you do have gut symptoms, so any bloating, any constipation, as I mentioned already, but any diarrhea, any wind, burping, gurgling, they're telling you that in addition to having maybe some hormonal issues, you have gut issues, and to fix the gut will assist with other aspects of absorption of nutrients, absorption of the chemicals that you're taking for your hormone replacement therapy, if you're on that or if you're thinking about it. So getting that gut sorted is very important. Now, loads of people take probiotics, and they are part of one of the plans or programs, options that I might put into someone's regime. But equally, we can get great probiotics and prebiotics from our food. And when we talk about prebiotics, they're the fibers in all sorts of fruits and vegetables and our grains, and our probiotics as well. And then you can also get them as a supplementation form, and there's a variety of different liquids and tablets and so on. So personally, they can be useful for a particular reason, and I certainly, as I say, do give people suggestions on probiotics if they need them, but they do tend to be expensive. And then one area that many people don't maybe appreciate is if you're taking something like an acidophilus, well, it's a one type probiotic. So hey, you're just recolonizing the same bacteria in your gut when we have trillions that we want to colonize. So you really want to get diversity, and plants and grains and good routes of protein really will be the answer there. And they also, getting that balance right, will knock on the door of better sleep. They will assist with mood, because if we have up and down blood sugar control, we get quite hangry, where we get hungry and angry because we've just got our energy levels going up and down. And so that's one of the aspects that can, also cause the feelings of anxiety, tension, stress. We need to be very level in the nutrients that we eat, in our macronutrients, so our general foods being the proteins, carbohydrates, fats. Now, we talked about omega-3s. I didn't talk about fats as a whole. And fats, we've got saturated, unhealthy, processed trans fats, but we also have good fats, the omega-3s, and we also have the unsaturated fat in a variety of natural products. So we do want to focus in on those, so our olive oils as well, the seeds, as I've mentioned, and fish. We get oils in our natural meats, so for sure you don't want to be excluding them. And if you're a vegan, then we do need to maybe think about a vegan alternative, so for some extra omega-3 fatty acids going in there. For brain cellular function, for all our cells, they are fat-based aligning. Now, when we do have aspects of poor blood sugar control and so on, we definitely need to think about, as Frances said, alcohol intake, caffeine intake. These are stimulants that can really drive our vasomotor and our feelings. So again, drawing you back to the ideal plate of good quality foods, fruits, vegetables. Small amounts of caffeine is fine, 2 to 3 cups of tea and coffee a day. Keep them before 3 or 4 in the afternoon, so they're not knocking on the door of affecting your sleep. Same with alcohol, but in the sense of, if you are having an alcoholic drink, 1 or 2 in the evening is probably going to give you the relaxation, the enjoyment, but it won't push you into a full sleep where then you're not getting a deep restorative sleep and you're waking hot and feeling rubbish the next day. Nutrients that you want to focus on for deeper quality sleep, for sure. We've touched on vitamin D with Frances. Most important as a hormonal balancer. It assists with inflammation, as we've highlighted. Inflammation is not what you want to be in an inflamed state, so vitamin D will help there. It helps with bone health. It helps with getting calcium into the bone, but you need vitamin K too with that. So again, if you're looking at vitamin D as a product or a supplement, you need vitamin D3 and vitamin K2 to assist you. So again, that's another add-on that you might want to put in or buy as a joint supplement instead of having to take 2 separately. Magnesium, a massive trace element that most people do not appreciate. We need, it's got 600 enzymatic functions in the body. It's so important to assist with a variety of heart conditions, brain health, as I said, the bone health, having calcium put into the bone. We need magnesium as a cofactor alongside that vitamin D and K2. So that's a combined approach for that bone health that we're talking about as we age and our bones become a lot more sensitive to deterioration because that estrogen isn't there to protect them. As well as joint pain, aches and pains, we've got that covered with the vitamin D and K2. So again, really important alongside the omega-3s that are also there for the inflammation and the joint pain. Collagen is a big one that people talk about and love to ask me questions on, and there's lots of different varieties of collagen, and you really need to be probably pretty considerate about, if you're going to start collagen, you have to keep collagen going, and it is expensive. So it's not necessarily the one thing that I'd go, hey, everybody, collagen's the answer. Put your money into tubs of collagen, and it needs to be marine, or it needs to be vegan, or it needs to be bovine. We don't quite know. Everybody's got different requirements for collagen. And so I would just personally say, if you can get it from your meat and fish and get your vitamin C to assist that collagen from your natural sources of the proteins that make up collagen, then that is a cleverer, cheaper, and more sustainable long-term benefit. Because if you start it, you can't really give it up, or the benefits of collagen quite quickly dissipate. Another area that a lot of people wouldn't be maybe aware of, and it's something that I don't use a lot of, but for people who are, again, wanting to feel the benefits of their workouts, more energy, and it may be not testosterone that you're looking at and wanting to replace, then creatine is one. At 5 grams of creatine a day can be useful. So again, that might be something to think about if you're interested in that. And looking at testosterone, yes, you can get testosterone as a hormone replacement, but actually, interestingly, you can drive up your testosterone if you can, as naturally as you can, with good sleep, with exercise. And exercise for women needs to be getting into lifting, putting strain on those muscles, building muscle. That is where you might get some improvements in that feeling of well-being naturally, rather than necessarily have to take some supplements or hormonal replacement. But I'm not saying that that's the answer. I'm just saying it's another thought process for you to consider, and I use with a lot of my patients. Very much, I think, fluids, we know that if we have only a small percentage of fluid losses, we feel exhausted, we feel lethargic, and that's for all age groups. But certainly as we get into our menopausal stage, we tend to maybe not drink as much fluid, or we just don't feel like water is our thing. And so we reach for the teas and coffees, which are far too much caffeine if we exceed the 3 to 4 a day. And then we reach for maybe some decaf. And then do we know that decaf is actually any better? A lot of decaffeinated products tend to have more chemicals added. So sorry if you're on a lot of decaf thinking it's the right thing to do. Just check that you've got more of a natural decaffeination process going on. So Clipper tea, for example, has a natural water based filtration. So it uses water to filtrate the caffeine. So that's a more natural version rather than chemicals. So that's again a top area that you can quickly win and change. Now, brain fog, we all experience it, and certainly that brain fog, that feeling of lethargy, that feeling of anxiety, depression, they all are tied into actually, again, these micronutrients that we've already highlighted, but equally B vitamins are really important. B vitamins are important for metabolism, for energy, folate's there for DNA replication, for depression. And if you have a methyl tetrahydrolate folate reductase enzyme issue, genetic issues that we can all have that we don't know about, then sometimes taking a B vitamin isn't always going to be the answer. You may take a stack of supplements and actually maybe making you feel worse because you're not actually making him activated, and it's using up various other nutrients like magnesium and vitamin D for the wrong reasons. And so you're actually having to go through a cycle twice. Whereas if you do have a problem with those types of areas, using a much more natural absorbable set of B vitamins from your grains, from your fruits and vegetables, from your meats and fishes, we get a variety of our nutrients and B vitamins from there. So I'm all about an orchestra. And when people throw in high levels of B12, thinking, oh, yeah, that's what I need. I've been told by the local health food shop, take a big high dose of B12 supplement. And you're like, I don't know if it's working. I actually feel more exhausted, or I feel more wired, or I feel more anxious. And that is because you've got the drumming of the drums banging rather than the whole orchestra and the woodwind and the violins playing. So you really need to recalculate what you take, how much you
All right, everyone, anybody, any questions at all that you have for Gillian? Go right ahead. You can put them in the chat box as well if you would rather not be on audio. Can we see any in the chat? No. Everyone seems really good. No questions.
Just one, can I ask one, Gillian? You've talked about a lot of different vitamins there. Is there, I know obviously you can't cover everything, but is there a particular multivitamin that you could take which would cover quite a few of them rather than having to, take like 10 different vitamins a day? Was there any multivitamins that you would recommend for people to take?
Good question. And actually, no. I see a lot of people who take multivitamins, as I highlighted, and they're all the wrong doses, or they are the wrong ingredients, or they have a lot of binders and fillers. You can take a multivitamin from the supermarket shelf, but they won't be necessarily helping the whole picture. And I'm not about, you know, taking all individual supplements. That is laborious and tricky. But definitely, Frances highlighted the vitamin D spray that she uses. That can be helpful as well. As regards a multi, you need to be careful. I know we've already heard from a lady there who has a liver cyst. She's fine, her liver function is fine, but I do get many people that have taken high-level multivitamins for multiple years and they have no clue. They haven't tracked or checked their bloods, and actually they have their liver function is elevated. They have given themselves more problems because these high-dose vitamins, if you look at vitamin A, vitamin D, vitamin E, and vitamin K, they're fat soluble, so they get stored in the body. They're not excreted like B vitamins and C that are expensive urine if you've got high levels that you don't, you know, make use of. So again, you do not want these things stored in the body unnecessarily at high doses if you don't need them. Iron is another big one that's in a lot of these over-the-counter vitamin and minerals. Iron we need titchy amounts of to keep us regulated and healthy, and certainly not when we're postmenopausal, particularly because we aren't passing or we're not having our period, so we're not losing that iron through that regular cycle. So again, we need to be super careful that we're not having high doses of iron in these supplements. So unfortunately, if you are someone who is not feeling the best and not having the outcomes of the HRT, I would suggest a trip to the GP and getting a couple of blood tests like your vitamin D, like your iron levels, like your B12.
Okay, that's great. Thank you, Gillian.
Okay, so if there's no more questions, or if there's no more questions directed at Gillian, Lisa's back in the room.
Hi, everyone.
Do you want to take over, Lisa? A lot of what I'd said earlier, a lot of what Frances has said, her and Lisa probably would have covered the same thing. But if there was anything that you felt you wanted to add, or if anybody wanted to ask, I've also put out that you would be more than happy to give your email so that if people want to ask any questions. We had one lady on who just didn't feel heard by her GP.
Yeah.
And she just doesn't, she's not quite sure she's getting what she wants from it. So I was just saying, you know, we could give your email and you could certainly advise next steps for anybody.
Yeah.
But if there's anything you want to add in.
I'm happy with that. I suppose it's to be it's perimenopause and menopause is just it's a very tricky phase of life, and it's really important to understand what it is and how it affects you and how to go about getting the best help for it. So it's by presenting to your GP or somebody like ourselves with your symptoms and kind of having an open discussion about whether you need HRT, whether it might be lifestyle management, exercise, lots of different things. And what we consider is you on the whole, your previous medical history, your family history, any risk factors that you might have, your lifestyle, and we kind of tailor our advice and our treatments towards that. A lot of women, I think Frances will have alluded to this, they don't feel heard by their GPs, and they are kind of labeled incorrectly as being kind of anxious or depressed when they're not, and given antidepressants, which is very frustrating. So I would encourage ladies to, you know, if that has happened to them, you know, to be persistent with the GP or even ask to speak to a different GP about how they might best manage their symptoms. Perimenopause, as Frances alluded to, is sometimes trickier and more difficult to manage than menopause. What happens during menopause obviously the hormone levels, they fade away. So particularly estrogen, progesterone, and testosterone. Estrogen in particular is really, really, really important for our brain. So it's really important for energy production in our brains. So if we, as we start to lose estrogen, we start to lose the ability to think clearly. It's very important for our cognition centers, our executive functioning centers, and therefore we end up with brain fog, short-term memory issues, you know, and that has an impact on work. Also, as Francis alluded to, very important for our thermoregulation centers. So it's like a fuel for our hippocampus and our thermoregulation centers, which sits in our brain. And if we don't have enough estrogen or fuel for that, what happens is we lose the ability to control our temperatures, which results in sweats and hot flashes. And the same goes for sleep centers. It's like a fuel, not enough for to keep us asleep at night. So it's important to kind of identify what your symptoms are and how we can best manage them. Does anyone have any particular questions regarding menopause? And also feel free to email me, you know, with any individual concerns, and I can certainly address those separately.
Somebody in chat? Don't see them. No? Oh, there's WeChat.
Oh,
Oh,
it's
we
in
have
here.
one. What's it say?
It's quite a thing.
I'm telling here's something that my wife has been going through menopause, and it's quite a thing for them to have a return. I find it shocking how little information is out there. I would like this about everything else.
You know what, if we'll read it out loud just so people can hear. I'll not say who it is, but it's just someone has said, I'm attending here as a husband, as my wife has been going through menopause. It is quite a thing, for want of a better term. I found it shocking how little information is out there. However, the likes of this webinar definitely helps. Many thanks. Well, I for one am very appreciative of a man coming on to it, because I say it all the time, you know, every man has a wife, a mother, a sister, a daughter, a colleague who is going through this. And as much as men always, people think men don't get involved in it, I think more men should.
Yeah.
So thank you so much for your question.
I think it's hugely encouraging to see that question. And also I do have a lot of men who attend with their wife or their partner for the consultation, and they sit there, they want to understand, they want to know how to help their partner and to understand what is happening. And they have seen maybe even more than she has realized, you know, these kind of personality changes or issues that she may be struggling with. And to have that extra support is amazing. Just a point on menopause and mental health. It can have huge impact on it can cause lots of psychological symptoms. So it's very important. Estrogen is very important building block for chemical messengers, which are called neurotransmitters, such as serotonin in our brain, which are kind of like our happy and calm hormones. So they can all go astray, particularly when the levels are falling. You'll find the serotonin levels fall, and you have these kind of inexplicable mood changes or anxiety levels, or sometimes even panic attacks. And a lot of women don't actually realize that there is a specific reason for that. It's not just a difficult phase in their life, it's that their hormone levels are dwindling. Also, estrogen is when we feel stressed, what happens is our cortisol level goes up, and cortisol has a direct negative impact on estrogen. So when our cortisol level goes up, our estrogen level goes down. So it's really important to try and understand how all the hormones are kind of interlinked and what they can do for our body, and how we can minimize this, whether it be HRT, whether it be lifestyle, whether it be diet, exercise, or a combination of the above.
We've got another question there. Do you want to read it out so everyone can hear it?
I am on an estrogen inhibitor. It depends which one you're on. If you want to email me about that separately, There are some you can and there are some you can't. I'm just wondering why you're on the estrogen inhibitor as well. Is it for kind of query endometriosis, or is it an increased risk of breast cancer or significant family history? So if you want to email me about that one separately, I'll know a little bit more. Some can, some can't, but I'll be able to tell you in more detail when you email.
Oh yeah, sorry, that was me putting that in.
Yes.
I'm okay to talk. Just yeah, I'm on these. It's a one called letrozole,
Yes.
and
Yes.
it's as a result I had breast cancer last year,
Mm.
and so I'm on that now. But I have been one of these ones that have been offered the antidepressant, you know,
Yes.
for the mood swings, because I've got menopause back with a vengeance. I had menopause before, but now I've got it back. So
Yeah.
I'm
Yes.
just wondering, would testosterone help?
In that instance, it wouldn't actually,
Right.
fortunately, but there are other suggestions I can give you if you want to even just fire me off a quick email there, and I can
Okay.
tell you what is available for you and what is safe for you to take, you know.
Okay.
But
Yep.
it's trickier, but it's possible, and there are other ways we can manage things.
Okay. That's grand. Thank you.
No worries. Have we any others? Is there any other in the chat? No. No, no other questions? Well, if you want to take, sorry, Gianna. If there's no other questions, what we can do is we can go ahead and probably wrap it up.
Yeah.
Sarah Jane, do you have anything you want to add in? As I say, I will share with Sarah Jane Lisa's email and she can send it out to you. Plus, we'll be able to share the recording of this for those colleagues that weren't able to make it, or for anybody that just wants to listen back on it afterwards. And I say, feel free to ask Lisa anything, whether it's on behalf of yourself or on behalf of someone else. We're more than happy to help out on this occasion.
Yeah. I'll send everybody a copy of the email as well, just in case you're not getting it from down there. So that's great. So it is.
Yeah. Have you anything else you want to add, Sarah Jane?
No, it's just to thank everybody, and just to say I'll send out the link as well then for the recording, and hope everybody found it informative and enjoyed today as well. So, and thank you to yourselves as well. Really appreciate it.
Well, apologies for all the tech issues and for running on and for everybody staying pretty much to the end. Well done, everybody. Unfortunately, these things are always sent to try us and with the best will in the world. And the amount of people we had and the preparation went into it still didn't go according to plan. So you can only but try. But no, thank you. We're delighted to be back with you. You've been a great crowd, second year in a row. So we're delighted to keep working alongside you guys. And as I say, if we can help in any way, just my email's there as well. Sarah Jane, you can share that as well. Is that another question? Do I have another one? Sorry. Oh, we put Lisa's email into the chat as well. But I'll send everything through and sure you can share whatever. And my email's there as well. If anybody needs anything from the hospital, should anybody have any questions about anything, feel free to come directly to me and we'll try and get you sorted. But other than that, thanks to both you and thanks to Barona for all her hard work and many emails. God love her. She has the patience of a saint when it comes to dealing with me. So I really appreciate all her help as well on this. So, but other than that, thank you so much, everyone.
Thanks, everyone.
Have a good day.
Bye.
Bye. Bye.